Hello and welcome to the Commonwealth Policy Center's special presentation on medical professionals' perspective on COVID-19. With us is the medical director of Baptist Health Hospital in Louisville, Dr. Thomas Davis. Dr. Davis, welcome to the program.
Thanks for having me. Excited to join.
Yeah, hey, it's really great to have you on. At this point, there's a lot of opinion out there on policies regarding COVID-19. There's conspiracy theories, if you will. There's just a lot of stuff flying around, and I thought it'd be really good to have you to share a medical professional's perspective. And not just that, you are the medical director of the emergency room at Baptist Health, and let me cue this up by giving an update as to where Kentucky is with the number of cases. There are 42,958 confirmed COVID-19 cases in Kentucky, 867 deaths. Not sure, I couldn't find how many recoveries there were in Kentucky. Worldwide, it's 22.2 million cases, 14.3 million people have recovered from COVID-19. 780,000 deaths worldwide due to COVID-19. The idea of social distancing was to slow the spread of COVID-19. It was to flatten the curve so that emergency room departments like yours would not be overwhelmed, so that the equipment such as ventilators and other emergency equipment would not be overwhelmed. Was there ever a time in Kentucky when there was a lack of emergency room beds or there was a shortage of ventilators at Baptist Health? Let's start with that.
I think there was certainly a concern that there could be a shortage. And the reason is that we have, as any business, you want to try to not overbuild your capacity. And so you try to match the supply and demand. Now, I will say part of this shortage, or the concern for shortage of beds, was because Kentucky is one of a few states that still has certificates of need that artificially eliminate a free market in healthcare in terms of the number of beds that we have available and in restricting healthcare services in other areas. And so we, in some ways, through policy, we created our own shortage in Kentucky and the concern for bed shortages because of our anti-free market policies. So there was, I think, a legitimate concern that there could be a shortage. Now, what actually happened is the demand for healthcare plummeted, in part because elective surgeries were canceled, but also people, it's amazing, a lot of chronic emergencies went away in Kentucky and throughout the state, and ourselves included. And so really the demand for healthcare services went away when people were more thoughtful about if they needed to be in the ER or not.
You have seen people with COVID come into Baptist Health symptoms. What are you seeing for somebody that has COVID, or what does it look like?
The symptoms of COVID. I'm sorry, kind of a little choppy.
Yeah, I'm sorry. What does it look like when somebody has COVID, when they come into the hospital? What are the symptoms?
Yeah, coronavirus is a virus just like any other respiratory virus. So there's a ton of overlap in symptoms. So you think about your common flu, common cold, they're going to share a lot of the same symptoms in terms of cough, fever, chills, having muscle aches. Certainly the most distinguishing features of this is a loss of taste or smell. It's by no means not every patient who has coronavirus has those symptoms, but when someone does mention that change in color in taste or smell, it certainly increases the likelihood that it is due to coronavirus. So that's the most distinguishing feature.
What age groups are impacted the most by coronavirus? Can we look at the different cohorts or different age groups and how they're impacted?
Yeah, so certainly the older we get, the more vulnerable we are. And that holds true with really any medical condition, no matter what you get, whether it be infectious or any other insult to your body. The older we are, the more vulnerable we are to the consequences of that medical condition. And so that same philosophy holds true with coronavirus. The oldest, really those Medicare age and older, are the most vulnerable.
Okay. And how does it impact the different age groups? Early on, we were concerned about young people, even though they weren't maybe expressing the worst symptoms, they were viewed as being carriers. Let's talk about that. Are young people, first of all, how vulnerable are they? And are they significant carriers of COVID-19?
Yeah, so early on, the concern was that younger children, just children across the board, would be, quote, the super spreader, where they were asymptomatic carriers of coronavirus and they would be infecting everybody around them without having any awareness of that. And really, our understanding has shifted tremendously. In a few things that need to be highlighted. First of all, we found that amongst children less than 14 of age, for sure, that their likelihood of dying from coronavirus is less than the flu. Second, children are much less likely to contract coronavirus. And we now understand why that is. So coronavirus gets into the body through a receptor in the mucous membranes, meaning your mouth, your nostrils, and your eyes. And it requires a receptor called the ACE receptor for coronavirus to bind to it and thereby get into the body. Well, children do not express that receptor in any kind of high levels, and therefore it protects children from contracting the virus. And without contracting the virus, they don't spread it. And what we've seen in other countries where they have gone back to school already, Denmark, the Netherlands, that there really has not been much spread at all due to children, especially the younger children.
Okay. I'm going to come back to that in just a minute, but I want to talk about the older population here in Kentucky that is impacted. My understanding that upwards of 80% of people who are expressing severe symptoms of COVID-19 and dying from it, they're elderly, 60 and older. I want to talk about, of course, as you mentioned earlier, the older we get, our immune systems aren't as effective. But I want to talk about comorbidities. Are you aware of comorbidities? And these are other secondary health issues. If somebody's diabetic or if they have lung issues, what have you, how do comorbidities factor into COVID-19 deaths? Do we have an idea of how many people that die from COVID-19 have a comorbidity?
Well, first of all, I think age is probably the biggest comorbidity, and it's the comorbidity that we can't control. However, another challenge that we have is we're also in the United States, and most of us have comorbidities of some kind, whether it be high blood pressure or being overweight. The reality is, though, that high blood pressure itself is not a strong, I would argue that it's not a strong determinant of a poor outcome. Although it does slightly increase your risk of having an adverse effect. What is much more concerning is someone who is elderly, who has more significant issues. I think obesity is a big issue. If they're morbidly obese, just because they have the obesity affects their lung function, having the extra weight on their chest. Additionally, being a poorly controlled diabetic, having kidney or liver issues are some of the comorbidities that concern me the most. Now, that being said, people will often say, oh, my child has asthma. I've not seen a lot of data specifically looking at that question, but I don't get particularly concerned if a young, healthy child has asthma, because like I said, the number one comorbidity is ultimately age.
Okay. How does coronavirus compare to other types of flus that we've seen? I understand that there are a handful of different flu viruses that surface every flu season. They're constantly active. How does this compare to other flu viruses that we've seen?
It's certainly a more lethal virus compared to others. It's not, when the initial reports came out, we were estimating upwards of, at times, a 15% mortality rate with the virus. And so this had the concern was this was a virus really never before seen or not seen in our lifetimes. But to be fair though, when MERS and SARS first came out in the last couple of decades and other similar viruses, there were similar reports of very high mortality rates. And similarly, once we adjusted and had more accurate data, we realized that those were significant overestimates in terms of their mortality. And we're seeing similar results, very similar results, same order of magnitude of being inaccurate with today's most recent data on coronavirus.
So 15% mortality rate was predicted early on. I understand that the models that they put together were off. One estimate said that we would expect 2.2 million people to die in this country alone. We're nowhere near that. It's in the 170,000 range. Still significant number of deaths. And I don't want to sound cavalier when we're talking about human life. We ought to protect human life. We want to progress and proceed carefully. When it comes to implementing safety measures that benefit all of us. But I'd like to talk about what is the actual mortality right now rate of COVID-19? Do we know?
This is a tough one to answer with full certainty because we don't always know what the denominator is. And that's really where I think antibody testing will be able to give us better insight. The numbers you have, how many people die with known confirmed cases of coronavirus and how many people die that didn't even realize they had coronavirus in the first place. And so it leads to some divergent estimates. I would say that our best estimate is maybe around 0.5, at most 1% from the most recent literature that I've seen, which obviously is very different from the 15% numbers that initially had been reported.
My understanding, Dr. Davis, is that the typical flu of the various varieties that are out there, the mortality rate was about 0.1% for those viruses. So you're talking, from what you've read regarding coronavirus, 0.5 to 1% mortality rate.
Correct. And to be honest, there are some reports that show even lower mortality rates. I think what is interesting is that it keeps getting downgraded, that number. I've not seen numbers going up. So what this number ultimately settles out to could be even lower than what I'm currently quoting. But certainly, I think the important thing to see is that the initial reports were significant overestimates of what we've actually experienced.
Okay. There has been concern that there has been overcounting of COVID-19 deaths. I just read a letter that was sent to some of our elected officials by a psychologist who counsels people, but he said that the CDC encouraged that suspect cases, and I'll use that term in suspect in quotes, suspect cases be counted in the number of deaths. It's also well known that positive test cases have been counted multiple times for a single patient. Are you aware of this, where there are multiple, countings of COVID-19 for a single patient, or is that maybe on the fringe of conspiracy?
I would like to think that the most recent data of positive cases are relatively accurate. I know that was an issue, for example, in Belgium, where they had very high rates and they were including a lot of suspected cases as deaths. I think the real issue is the denominator. We don't know what the true denominator is. And, I'd say early on in the state of Kentucky specifically, we were asked to fill out paperwork for every test that we did. Well, we've all seen the lines of how long unemployment lines got in Frankfurt. The Department of Health has the exact same issues of being totally overrun with paperwork. Now, I have very poor confidence they're able to keep. I know they can't, to be quite honest. They have not been able to keep up with all the paperwork that they have requested of us. And I do have some concerns about their ability to keep up with the denominator.
Sure. Another interesting thing has been brought to my attention about the federal government reimbursing hospitals and other medical entities for those confirmed cases and those that they're treating. It's a number of somewhere between $15,000 to $40,000 per patient. Does this create a perverse incentive, perhaps, for hospitals to classify somebody as COVID-19? And again, I don't want to get too far out into speculation, but it would seem that perhaps there would be an incentive there to classify somebody as a COVID positive. And again, I want to be careful how I ask this because there is a financial incentive for for a hospital or a medical entity to classify somebody as COVID positive. So are you aware of this, or have you given much thought to this?
I think that is a very valid concern. And again, I don't know, I'm not sure how the state is counting and how the United States are counting all of their positive cases. I hope they're counting at this point with just the PCR tests that are confirmed with the nasal swab. But you're totally right in that there is a very big financial incentive to label anybody who comes in with possible COVID symptoms as, quote, suspected COVID.
Let me try to flesh this out. And as my thoughts are gelling, always dangerous to think out loud in a live interview like this. But so let's say somebody comes into Baptist Health emergency room with another significant comorbidity. Let's say it's somebody that is morbidly obese. Let's say that they have asthma, breathing issues, and they may test positive for COVID-19, but the real issue is with their asthma and with the other effects. And perhaps in that situation, the COVID-19 isn't impacting them like their other health issues are. The hospital is going to get reimbursed for treating that person, perhaps primarily for the other issues they're dealing with and not so much COVID-19. That's my theoretical that I'll put out there. Is that reasonable, that could be happening?
I want to make sure I understand. So repeat what you just said. I just want to make sure I understand your thought process correctly before I comment on it.
Yeah. So if somebody comes in to the ER with other comorbidities, other significant health issues, and they test positive for COVID-19, and let's say COVID-19 was not really the driver or the thing that's being treated, it's the other health issues. It's somebody that's morbidly obese, they've got asthma, maybe they're a diabetic. They've got these other things going on that the hospital could be treating for. And again, probably they'd have breathing issues, but who's to say it wasn't the asthma or these other things? And I guess what I'm getting to is, can COVID-19 not express itself, even though that somebody might test positive, maybe they're positive, but that's not having the impact like these other secondary health issues are affecting them? Does that make sense at all?
Yeah,
And I don't know if that's a good question or not. Yeah.
It's hard to tease the two apart in terms of are there symptoms due to COVID-19 or their underlying issue. I think it's really hard to pull those two apart and have any kind of confidence to say what is the driving factor. What I was talking about a little bit earlier, what does concern me a little bit in terms of having an accurate numerator, though, is that there's a big incentive to label anybody as suspected COVID, because there is guaranteed reimbursement if someone is uninsured. As long as you label them as suspected COVID, you're guaranteed to get money to help pay for that person's visit. And it creates a financial incentive to over-label people as being COVID-19.
Dr. Davis, do you have any idea how many people Baptist Health has found to be coronavirus positive? Any idea on the numbers that have come through your doors? Oh, I think I lost you. I'm not able to hear you.
I'm sorry. Yes, I do have an idea. I don't have those numbers on the top of my head. But I'd have to look those up. But I do have a general sense of how many we've had. I could look those up if needed.
Okay. How many, and we talked about the beds being available. You've not had a shortage of beds at Baptist Health. How about ventilators? Has there been a shortage of, at any one point during the COVID crisis that we're in? Has there ever been a shortage of ventilators in the hospital?
In terms of ventilators, no, we have not. We were certainly concerned there could be. I would say for the past almost month now, we've had between 0 and 2 patients on the ventilator at any time in our hospital. When we're one of the largest hospitals in the areas and potentially the state as well. And so I am very encouraged that the demand for ventilators has actually been much lower and has been really the lowest point we've seen since all of this started.
Okay. How about PPE, personal protective equipment? I heard a story yesterday on NPR talking about a shortage at some medical facilities across the country where they're facing a shortage of whether it's masks or gloves, things of that nature. Are you aware of any shortage at Baptist Health?
At this point, no. There were some real concerns about a shortage early on. And a lot of it was because we didn't know how to use masks. Some people wanted to throw out a mask after every patient that we saw, and that certainly consumes a lot more masks. But I think we've all settled into realizing that you can wear one mask and have prolonged use, and you're adequately able to protect yourself and others in the hospital setting with the surgical masks. And between that and the increased supply, I don't have any concerns at this point of our PPE usage.
Okay, let's talk about masks a little bit, Dr. Davis. Are masks an effective way to slow the spread? We, right now in Kentucky, have a mandatory mask order if you are in a public place or if you're outdoors and within 6 feet of other people. Governor Beshear has ordered that you wear a mask. Is wearing a mask effective in slowing the spread of COVID-19?
Let me first tell you how I'm going to answer all of these questions is that I'm going to, one, try to be very evidence-based and relate to you what the current status of the evidence shows. I also want to point out that the absence of evidence does not mean the absence of benefit. And that holds true for a lot of different therapies in medicine, and not just all the questions that we're talking about. So in terms of the masks, the efficacy of masks, there are a couple concerns that I see here. One, the evidence to support mask usage is based on extremely low quality data, and really almost to the point of it being a theoretical benefit. I think if you were to build a case for masks, I think the most compelling evidence is using surgical masks, which we have wanted to preserve for healthcare facilities in particular. Conversely, regarding the use of cloth masks, there had been, prior to COVID, there had been relatively little literature on the effectiveness of masks. There was a very interesting randomized trial, arguably ultimately the highest quality evidence that exists. And it was published in the British Medical Journal, and it showed that in this randomized study that use of cloth masks actually increased the risk for infection.
Wow.
For getting ill.
Can you explain that? Can you tell us why that is?
The thought and the concern, and they were hypothesizing why that is. The thought and the concern was that using a cloth mask for prolonged periods of time can get dirty, that it can trap the moisture around your mouth in the cloth, and it can become, in some ways, a petri dish. And so that was some data on a different viral illnesses that had been studied. And so it creates some concern that masks could cause more harm than good, and that it may also distract us from other interventions that are also important, that we find that to be, as long as I wear a mask, I'm safe, and we don't pay as much attention to things like social distancing. So I think you can build a theoretical case that masks may be beneficial, but there is some real data concerns that it could be harmful as well. So at the end of the day, I would say the data are as clear as mud in terms of what the right thing to do is. And I don't know if you can convincingly, using evidence, say with any kind of definitive statement that mask wearing is, looking at the research, an essential intervention.
How about for people? So I appreciate that. I appreciate you explaining that in more detail. How about for somebody that might be COVID-19 positive and they're sneezing? I'm not sure if sneezing is one of their symptoms, but would it not slow the spread of the aerosol distribution of COVID-19?
So there are a couple of things you said. First of all, like I mentioned earlier, I don't. One of the concerns with masks early on was that if people wear a mask, they're going to forget the other things that are important. And I would say much more important than wearing a mask if you have COVID-19 is to stay at home, because you shouldn't be going out in the community if you have COVID-19 and spreading this. And that's much more effective than a mask. Now, the other thing mentioned was aerosols. The one of the big concerns is that cloth masks do essentially nothing to contain aerosols because they're so porous, which is, and surgical masks are not great either, but they're certainly better than a cloth mask. And that's why I say, if you're building a case on theory, not with data, but with more of theoretical argument, that a surgical mask would be a more compelling argument than universal cloth masking.
Okay, very good. I'd like to go to a survey by the Centers for Disease Control released earlier this week. They found that 1 out of 4 young people between the ages of 18 and 24 had contemplated suicide within the last month. 40% of that age group reported struggling with mental health or behavioral issues. 13% of that age group said that they had abused drugs or alcohol within that same period of time. So we're seeing particularly the younger people impacted by the physical distancing mandates, by the shutdown of schools and certain parts of the economy. And I want to go back to, so tying that into what we talked about younger people, you said age 14 and younger, and absolutely fascinating. I've not heard this before, but there's a less chance of that age group, 14 and younger, dying from COVID-19 than from the common flu, whatever variety that is. What would be a better approach? Well, let's just talk about schools. The governor said that schools should be postponed for in-person classes until September the 28th. And yet the data says that young people aren't as vulnerable to COVID-19, dying from COVID-19 as from other diseases. What would be how would you respond to that? And I'm juxtaposing the mental health and the substance abuse issues. And again, a little different age group we're talking here, but generally we do know that younger people aren't impacted by COVID-19 like older people are.
It's
But
a
I'm
lot to unpack in this.
that's true. That is a lot.
Let me,
I'm
if you
trying
don't
to
mind me
find it.
breaking it up a little bit, because you made me think of a few things.
Yeah, please do.
So first of all, you talk about survey data of young folks, and I've seen a lot of that survey data. I've not really seen much survey data on the elderly and how this has impacted the elderly, because what I have seen in the ER is a tremendous sense of isolation and loneliness amongst those who are older. And I think we need to remember that they a lot of times are being the most affected by this disease by being so isolated. And I would love to see survey data on that specifically. And it makes me think of a little story that one of the techs in the ER came up to me and said, "Hey, Dr. Davis, I'm really concerned about my mother. She's got stage 4 breast cancer, and I don't want to get her infected with coronavirus. I work in the hospital, but I really want to see her. What should I do?" And I said, "Well, tell me about your mom. How long does she have left to live?" He said, "Well, about 2 months." And I said, "Listen, you go see your mom every single day, because so what? She's all, she doesn't have much time left on this earth. And so what if she gets coronavirus? If she were to die because of it, at least you got to see her every day."
Wow.
And I think the reason that story is important is because we need to remember that this is not a one-size-fits-all solution for Kentucky. We all have personal stories and lives that bureaucrats don't understand about what we're personally going through. And we need to give people, empower them to make decisions that are appropriate for their own personal situation. And I think that's really important to remember. And I think that same philosophy also applies to education as well, and letting the schools find a solution that fits the needs of their local community. So going back to education and some of that data, you're totally right. If you look at the data say that children are less likely to get coronavirus and are much less likely to have any negative effects, much less so than the flu. And if we're not closing schools for the flu, why are we doing this for coronavirus? That's a compelling argument, and there are some thoughtful counterpoints to that. But I think we need to make sure that we're following the data. And certainly the American Academy of Pediatrics has advocated for children being back in school, and I think we need to seriously do that.
Yeah. No, thanks. And I appreciate that. That's a great perspective. Sorry to throw so much out there at once. I'm trying to make some connections though. Let's go to the CDC and their survey about mental health of 18 to 24-year-olds. A significant number, 1 out of 4, have considered suicide in the last month, which is alarming. Have policymakers considered the secondary effects of closing schools or shutting down parts of the economy, separating peer groups? Have they considered the overall health impacts? Mental health is part of our overall health, but have policymakers thoroughly considered how shutdown affects others?
I think some probably have, but at the same time, there are so many confounding variables that need to be integrated, and those are hard to measure directly. Whereas it's much easier to measure the mortality of COVID, and so all those other variables get lost in the conversation because the focus becomes on a singular variable, which is the number of COVID deaths, and it's hard to accurately account for those other variables. That doesn't mean that they shouldn't be, because they're also very important factors.
Yeah, that's good. That's good. Say, Dr. Davis, we are running out of time. I do want to ask one more question about hydroxychloroquine. That seems to be a hot topic. What are your thoughts on that as a drug that could be prescribed to treat COVID-19?
Yeah. So similar to the masks, my approach is talking about the evidence and what that shows. So I think masks they have low quality evidence. I think that hydroxychloroquine also has very low quality evidence. At this point, I would not recommend hydroxychloroquine. Again, though, the absence of evidence does not mean the absence of benefit. And so we've seen that in a lot of cases, like in strokes and stroke research, where initial therapies were not beneficial, and then we found subsets of the population that did benefit. And so I'm open-minded, but the best, highest quality data, the randomized studies, have not shown benefit with hydroxychloroquine. There are some lower quality studies that looked retrospectively back in time and showed some benefit, although there are mixed signals. And there is a real risk to medicines like hydroxychloroquine in terms of their effect to the heart. So I would be very cautious about its use. I will say nothing so far has been. I don't think it will be any kind of panacea to fix this. Even if we are able to find a subset of population that benefits, ultimately social distancing is appropriate, and a vaccine is going to be the best therapy that we can have.
Since you brought up vaccine, is there any idea when we might expect a vaccine to be available to the public?
I was very pessimistic early on. I've become increasingly optimistic, listening to and reading the research that's come through the New England Journal of Medicine, that things are going at a very favorable pace. I've been pleasantly surprised. I'm cautiously optimistic because I know how many hoops you have to either jump through and hurdles you have to overcome. So, but I've been very surprised by how progress seems to be going with vaccine development. But giving it an ETA, I think, would be unwise at this point.
Sure. Very good. We're looking for some hope out there.
Certainly.
Do you need any final words, any thoughts as we progress here in Kentucky as we move forward? Before we close this program, any last words?
I think that like I talked about, it's not a one size fits all solution. I personally think the best approach is to segment the population in terms of those who are most vulnerable and the highest risk, and those who are at very low risk. And I think we need to keep that in mind as an approach to how to best tackle this without totally dismantling our society and our economy. And unfortunately, that's not been the approach that's been talked about as much.
Yeah, very good. Dr. Thomas Davis, thank you so much for joining us. God bless you and stay well.
Thank you. Thanks for all the great work you guys do.
Thank you.